স্যার এখন তো স্যার 10 সেকেন্ড পরে থেকে স্যার কথা বলা শুরু করতে পারবেন স্যার। আফটার 10 সেকেন্ড ইউ ক্যান স্টার্ট স্যার।
হ্যাঁ, ঠিক আছে। Assalamu alaikum. Good evening. Welcome to this exciting session. How should I treat? Learn from experts. We know we have 3 experts today: Dr. Munwar, sir, Dr. Kaisar Nasrullah Khan, also Dr. Shohid A. Merchant from Mumbai. He will join very soon. We are very much delighted. Our respected director, sir, of an ICPD, Mirza Master here. Also, Professor Akim Reja, Professor Azia Sultana from, I think, Canada, Professor Saidur Rahman, Professor Abdul Jamil, Tamjid Ahmed, and lots of Dr. Urun Maski from Nepal also here. Professor Amal Kumar Chaudhary joined now. So I am requesting Professor Dr. Chaudhary Meskat Ahmed, sir, you will chair today's session. Sir, you start your session, sir.
Thank you very much, Dr. Mohsin. I'm very fortunate to have to chair this session. And today we have a very important discussion on how I should treat the case. And to speak on this topic today, we have the 2 renowned cardiologists, interventional cardiologists from the home and one from abroad. And the cardiologist from the home, Dr. Munwar and Dr. Kaisar Nasrullah, from the day 1 in interventional cardiology, they have started doing intervention with integrity and authority. And now in the country, they are the 2 most authentic interventional cardiologists of the country. So what could be more we expect other than this to have speak on the topics of how I should treat deletion. So without occupying any more time, let us go to the our main occasion.
Thank you, sir. At first, Dr. Munwar, sir, will introduce his case and patient profile. Then Dr. Kaisar Nasrullah Khan present how he should treat the lesion. Then Dr. Merchant will speak. At the last session, Dr. Munwar will present how did he manage this case, the cases. Now I am requesting Dr. Munwar, please introduce the case and his patient profile.
Thank you very much. A very good evening. Assalamu alaikum. Thank you to IPDI to allowing me to present this case. This is rather a simple case actually. It's not a very complicated or difficult decision-making case. But this is a type of case which will be faced by our fellows and cardiologists, everybody in the middle of night. They have to make a decision what to do. And this is really to ignite some discussion. So I'm going to start this now. I'm share my screen. Okay, so everybody can see?
Yes, sir.
Okay, thank you. Let's start. This is a acute anterior MI with cardiogenic shock in a 72-year-old patient with calcific TVD and old and chronic neurological problem, and how to treat this condition. So this patient, a 72-year-old male, presented to our emergency room right at the middle of night with acute anterior wall ST elevated MI with ongoing chest pain with unrecordable BP. This gentleman had a history of CVD a year ago, and he was partially disabled from this CVD. In addition, he has got an old inoperable meningioma, and his CAD risk factors include hypertension, dyslipidemia, he is an aged person. In addition, his old CVD, and on the top of everything, he has got known CKD, which is stable CKD. So this man presented with cardiogenic shock. Considering his condition, we discussed the family, took the consent, and shifted him to cath lab. So did an urgent coronary angiogram right in the middle of night. His left main, I'm giving a short summary then showing the pictures. His left main showed distal calcification. LED is a good sized vessel with calcification and occluded right after proximal S1. Ramus intermedius is a big size artery with a long 18 to 90% osteoproximal to mid segment lesion. The main L6 is a small size vessel with a diffuse disease. A right coronary artery is a dominant artery but calcific with 60% proximal and mid segment plaque. So I'm going to the picture. You can see the left main is not bad. LED is, sorry. So LED is occluded, you can see right after the origin. Ramus is a rather big artery and L6 is a very small one, main L6. There is a cranial view. You can see the thrombus there, right here. This is a spider view. And you can see the bulk of thrombus inside the LED. At the same time, the ramus is not a bad one. It's quite a biggish artery. This is the right coronary, dominant artery with multiple plaque, but it appears manageable. So, in summary, this is a 72-year-old male with acute anteroceptal MI, ongoing pain, and cardiogenic shock with multiple comorbidities and very high syntax score. Syntax score actually is not really important in acute MI, but still I calculated just for academic discussion. And what to do next? And how should I treat this patient? Should I treat this patient conservatively? In which case, it's quite certain that this patient will not survive. Second option, should I send the patient to CABG, considering triple vessel disease? His syntax 1 score is 35, but is very likely, considering his comorbidities and condition, this patient is unlikely to come out from the operation theater. Third option remained primary PCI. If I do primary PCI, then is it culprit lesion only, or culprit plus stage PCI for non-culprit vessel, or the same sitting primary for culprit with non-culprit vessel together, keeping in mind he's got untreatable conditions of old CVD and a space accumulation and his stable CKD. What should he do? Now I'll hand over to my respectable colleagues for the discussion. I'm stopping my share here.
Thank you, sir. It is not an easy case, sir. The patient is 70 years old male.
Yes, of course.
And
But this is the sort of case. This is the sort of case Feroz will be facing in the middle of night. That's why.
Yeah, it's calcified lesion.
Yeah.
Not so easy. We are looking towards Dr. Kaisar Nasrullah Khan. Dr. Kaisar bhai, please share your screen. Kaisar bhai, unmute yourself. Dr. Kaisar Nasrullah Khan, please unmute yourself.
Am I audible now?
Yes,
Yes,
you are.
Yes.
Okay. Okay. Assalamu alaikum and good evening to all. Really honored to discuss about this case in front of such a learned gathering. Hope we will learn from each other to treat our patients better. Nothing to disclose. Well, gaining knowledge is the first step to wisdom. Sharing it is the first step to humanity. I would like to express my heartfelt thanks to IPDI for arranging this sort of webinars in this COVID situation for this noble purpose. Now, whatever my learned colleague, Dr. Shansmara, has told, in summary, key points are an elderly patient 72 years. Presented in ER with acute anterior STEMI, cardiogenic shock because non-recordable BP. Risk factor pressure, dyslipidemia, comorbidities, CKD, CVD, inoperable meningioma. Emergency CAG, TVD, though it's an MI case, but he calculated the syntax score, which is 35. But in MI, if you do grace score, I think it would be high grace score. And the angiogram, which is just now shown by Dr. Shams Munwar, LED 100% meet with calcification and thrombus, ramus, big branch 80% proximal, SARC, small vessel but diffuse disease, RCA 50 to 60% meet. So in this scenario, how should I treat? That's the question. My first answer will be, I will say that, well, you know, the patient has lived 72 years and average age of Bangladeshi citizens are 70 years. So I think it's enough for a person. Let's pray for him to God and let's quit here. I would not dare to take this case in this situation. It's my first response. Second response, if I am pushed to, I will refer to Savior, like an angel praying to God that who can come and save me in these situations. One would be who will be talking after me from Lilavati Hospital, Mr. Dr. Marchant, and second will be my senior colleague and my very respected and very good human being and also interventional cardiologist, Dr. Shams Munwar. But even as I'm pushed to say something, I will try to say my plan if I am in this situation. Now questions are, as has been asked, question 1, treat conservatively, send patient for cabbage or primary PCI. Question 2, if PCI, then culprit lesion only or culprit plus stage PCI for non-culprit vessels, or same sitting primary for culprit with non-culprit vessel together. Question 3, well, about comorbidities like old CBT with SOL and CKD. So let's take one by one. Question 1, should we treat conservatively, send for cabbage, primary PCI? So you all know the latest guideline, ESC guideline, primary PCI is 1A indication of any case of acute anterior STEMI. But if primary PCI cannot be performed within 120 minutes, we can think of fibrinolysis. So here, getting this case in a hospital where there's cath lab facilities, I think we should not doubt about what to do, because now in the latest guideline, the time limit has been extended even up to 24 to 48 hours. So ESC 2017 latest guideline recommends primary PCI in infarct-related artery as class 1 indication. Cabbage in patient with ongoing ischemia and large areas of at-risk myocardium if IRA is not amenable to PCI. So if primary PCI can't be done for some reason, then cabbage would be considered as a second choice. So answer to the question number 1 is, we can't defer the pace for cabbage because it's time consuming and might be fatal at the moment. Conservative approach is not an option at all. Patient is in cardiogenic shock. So for me, primary PCI is the preferred option. Question 2, if PCI, should we do culprit lesion only or culprit plus stage PCI for non-culprit vessel, or same sitting primary for culprit with non-culprit vessel together? Well, according to the latest ESC guideline, definitely the strategy is to treat only the infarct-related artery during primary PCI. And it has been told that in the guideline that routine revasculation of non-RIA lesions should be considered in STMI with multivessel disease before hospital discharge. So usually we do the culprit lesion in the same sitting, IRA, and non-IRA maybe after some days, maybe 4 to 5 days or 7 days in a staged procedure before the patient discharged from hospital. And also AHA guideline, same thing has been echoed as an indications. So if you see the culprit shock trial, the risk of death and renal replacement therapy at 30 days in patient with undergoing primary PCI with cardiogenic shock was lower with culprit lesion only PCI than with immediate multivessel PCI, and mortality did not differ significantly between the two groups at 1 year follow-up. So maybe in 30 days follow-up, it's shown a bit higher in the patients who have been done both IRA and non-IRA. But in other 4 large study favored multivessel PCI if patient is hemodynamically stable, not in shock. In the PRAMI, Civil Elprit, Danami 3, and also Prague 13 trials. So in patient with cardiogenic shock, if STMI with multivessel disease and cardiogenic shock, the culprit lesion only versus multivessel PCI in cardiogenic shock culprit shock trial randomized 706 patients to either PCI of the culprit lesion only, option of staged revasculation of non-culprit lesion, or immediate multivessel PCI. But at 30 days, they've already told the endpoints of death and renal therapy and death alone were lower in culprit lesion only group. It has been also shown in the British Columbia Cardiac Registry study as well. And latest 2019 Canadian Association of Interventional Cardiology guideline has shown that the bottom flowchart, you can see there's a multivessel PCI in case of primary PCI. If hemodynamically stable patient, then we can think of complete revasculation. But if in cardiogenic shock, we should not perform non-culprit lesion at the same sitting. The question 2.
Yeah, of course.
So considering the patient here in shock with lots of untreatable condition, we prefer to address the culprit vessel only. The non-IRA, the case of big ramus intermediates, will be done in stage procedure. Now question 3. Untreatable conditions or comorbidities like old CVD with SOL and CKD. CVD with meningioma, this patient which he had, so we'll think of, we know all 3rd generation DS, we can use dual antiplatelet for 1 month, then single after then, and can be stopped if future operation is required for a small period. Also, we will be very cautious to use other glycoprotein 2B3 inhibitor and extra heparin because of the previous history of CVD. So in this case, I will not use any glycoprotein 2B3 inhibitor and use minimum dose of heparin to do this case, considering his CVD. About CKD, we all know patient with CKD, the revasculation of PCI, if patient has CKD or contrast-induced nephropathy, the morbidity and mortality increases drastically. And whatever we have tried, like N-acetylcysteine sodium bicarb or contrast, which you say, it does not show any proved clinical evidence of benefit. So only clinically validated strategies for CKD are hydration. So for this patient, we will hydrate him properly with normal saline, of course, and also with inotrope to raise his blood pressure and monitor his urinary output. not particularly for this patient because it is a cardiac shock patient, but in cold patient, we can think of for CKD patients, the minimum contrast or zero contrast angioplasty with the help of IVAS. So question 3, considering CVD, I will not use glycoprotein 2B3 inhibitor and also use minimum dose of heparin. And considering CKD, IV hydration, non-ionic dye, and monitor urinary output. And he might need dialysis also later, for which I should consult with my nephrology consultant and make an arrangement. And keep a line in the venous, in the femoral side, because in the midnight, if urine stops, so that they can come and just put a wire and change the thing. Otherwise, these things brings out hematoma at night. So my plan of action, after answering these 3 questions, which has been asked by my previous colleague, for this particular case, I would prefer loading dose of clopidogrel and aspirin and avoid prasugrel to reduce the intracranial bleeding risk. We would prefer radial route. Guiding, I would like to take 7 French. In this case, for like thrombosuction or any Baylor procedure for left main dissections. And I will first, of course, I will raise his blood pressure first by giving inotrope, and impeller is not available in my lab, so I will use IABP, which is available with intensivist with backup support for ventilation, because this patient can crash anytime and he might need intubation. I would prefer single stent strategy with switch to provisional stenting cap technique in case of ramus gets compromised, but I will keep my stent proximal edge after ramus, just covering the mid-LED lesion, keeping it very simple. Would try to open the culprit vessel where in ramus, as LED seems to have thrombus burden and some calcification can be seen in LED. I prefer to use a microcatheter with a workhorse wire in LED. If it fails to cross, then I would step up the wire accordingly, like Fielder XTR or XT maybe. I will use suction catheter up front in this case and avoid glycoprotein 2B3 inhibitor to reduce bleeding risk, and at the same time reduce the thrombus load. And when I will take the thrombosuction catheter distally, then I will put some adenosine or like verapamil there to prevent the slow flow, no flow. Predilation not planned if lesion is soft, but preferable if hard to negotiate. Imaging in the form of IVAS would of help to detect ostial LED disease and the exact location of the lesion to keep the stent size to minimum. I will prefer to skip the LED ostium and keep it in the proximal LED after ramus. Well, my strategy will be single stent strategy, but if LED osteum is diseased, left main to LED single stent strategy should be planned, keeping a wire in the ramus. And if there is pinching, then maybe I will go for tap. And in the case of failed PCI to LED, because there is calcium, I'm not sure whether it will open or not. After when I negotiate the thrombus, then I will understand how it behaves with balloon or stents, balloon burst. Then maybe at least save a big territory, I will only stent ramus intermediates. If I can't cross LED or can't dilate LED, I will go for ramus at the moment. And of course, after doing the primary assay in a staged procedure, maybe after 5 to 7 days, I would like to address the ramus because it's also a big one, but that is also before hospital discharge. To summarize, primary PCI of the IRA only through the patient is in shock considering multiple comorbidities with complete revascularization before discharge or later with separate admission depending on patient outcome of primary PCI. Provisional one stent technique with minimum dye with lower non-ionic dye, IAP support, emergency backup or ventilation. That is my plan of action in summary. Yes, I would like to one similar case of mine. Mr. X, 65 years old gentleman, came with acute anterior STMI in my ear. This is his ECG, and you can see that RC is totally occluded, probably CTO, and LD was totally occluded after D1. L6 is diseased and very small caliber, like this vessel. And there is a ramus, big ramus, you can see, more or less similar case. So what I did, I wired LED, and then I sucked the thrombus because there is a large chunk of thrombus, then given distally adenosine and verapamil. And after suction, the thrombus burden has been reduced. And I went for direct stenting because I find that it's a soft lesion because primary PCI. So took a long stent because diffuse disease, put the stent, and post-dilation done. And you can see the final shot. I didn't do the RCA at the same sitting. So patient was maybe discharged, no, patient was staged after 1 month. And I checked the LED stent, it was more or less good. Then I tackled the CTO. And this was the CTO result. It's a stage procedure, a big RCA. Thank you.
Thank you, Dr. Kaisar. I think you explained all the thing, explained very nicely. All the points I think you touched. Yeah. I am requesting Dr. Arun Maske. Dr. Arun Maske, do you hear me?
Yes.
Yeah. What about the case and discussion? Dr. Samsponor and Dr. Kaisar, any comments or any question or?
Yeah, I
the,
mean,
yeah.
Whatever Dr. Kaisar has described, everything was described nicely. I don't think I have anything to talk, but as he has rightly pointed out, patient in shock, CKD, use minimum of dye. If possible, use support, and whatever support, IABP or whatever you have, that will make things easier. And Kaisar is a good operator of CTO. So it will be very easy for him to open LED. And imaging, I mean, it's a luxury. If you have, it's good. If you don't have also, the aim is to make it very simple, open LED. And once the patient comes up, then you can tackle other lesions. So that's what a simple strategy.
Thank you, Dr. Arun. Professor Mirjamal sir is with you. Dr. Professor Mirjamal sir, did you comment before Dr. Marchand also here? Before with the Marchand, Dr. Professor Mirjamal sir, please comment. Sir, please unmute yourself, sir. Please unmute, sir. Dr. Marchand, assalamu alaikum.
Walaikum salam, Professor. How are you?
Fine. Here, Dr. Professor Mirjamaluddin, he's the director of NICBD. He will give them some comment. After that, you present your cases. Dr. Professor Mirjamal.
Good evening, Dr. Marchand, and good evening to all of you. It's my pleasure to tell something about this case in this scenario and in this occasion. Dr. Kaisar Nasrullah Khan has nicely expressed what he will do. To me, this is exactly almost same, but one or two things I like to differ humbly, that regarding using of IABP, nowadays in shock trial, probably there is no so far benefit with IABP or without IABP in cardiogenic shock. And second one, after 1 month, the next PCI, that is also I differ a bit, that it should be done in the indexed hospitalization. Otherwise, risk is more. So if we do in the second option, meaning that second vessel ramus intermedius intervention, then it is better to do in the index hospitalization. Third one, he has told that if I I have to do the LM to LED, then I shall have to do LM to LED first, and then, if necessary, tap to ramus intermedius. But the ramus intermedius lesion is very tight, more than 90% lesion. So if I have to give the stent from LM to LED, then I shall have to pre-treat the ramus intermedius. Otherwise, this re-enter into this ramus intermedius, I think, a bit difficult. Though we want to make it simple, what he have also told, that from the mid lesion of LED, we shall have to cover. That is the most ideal, I think. And if I have to do the standing from LM to LED professional standing, then I shall have to pre-treat the ramus intermedius. And regarding the thrombus section, that is, in this case, mass thrombus load is there. So individual case basis, the thrombus suction can be done. Regarding the imaging, in acute setting, acute ST elevation myocardial infarction, we shall have to know that our initial purpose is to below wire crossing time and to open the vessel and make the TB3 flow. So with using in every center, there is also no facility for this IVAS or imaging facility. So where there is no imaging facility, I think no need, and where there is possibility, we can use, but it will take much time, and that is why I want to differ from it. And you have told that you want to do it as because the patient is also have CKD, so there will be less dye. This is also a very good proposal for this case. Thank you all.
Thank you, sir. I just a brief introduction, Dr. Marchand. You know everybody. He is the senior expert cardiologist in Mumbai, Lilavati Hospital and Heart Institute. Also founder member of this hospital. Not only is the excellent interventional cardiologist, he also some patron of different program in different parts of the world, especially the Middle East and other countries. He also worked in Europe and Australia also. Dr. Marchand, we are so much grateful to be here with your busy schedule, and I think you have family program. So, Dr. Marchand, please few comments regarding this program.
Yes, Dr. Mohsin, thank you very much for giving me this opportunity. In fact, I'm in the middle of something, but I've been so impressed with the IPDI that I thought that let me just intervene. I came out of a meeting to just say hello to you people. And regarding the particular case, I gave my opinion in the morning, which is a recorded version. Maybe you can play it. And I feel I've not heard the total lecture, but it's a tough case for anybody. And I have given you my opinion, maybe a few points to learn from. I think majority already discussed. And I thank you again. In fact, we are running a global cardiology forum where we have various invitees around the globe. And inshallah, in the future, we will get IPDI involved at a global level and take it to a new forum altogether. Thank you very much, Dr. Chowdhury ji and Dr. Mohsin Ahmed, for your very, very kind introduction and opportunity given to me.
Thank you, sir. Yeah, he also advisor of the IPDI. We are so much grateful to you to being with us as an advisor. Thank you, sir. Dr. Kamrul, Mr. Kamrul, please, yes,
sir.
Share his recorded video.
Yes, sir.
Yes. Thank you, sir. Dr. Marchand, thank you. You can.
It's a which you and also a meningioma. His coronary angiography shows a left main which is calcified, and LED which shows proximal calcification with total occlusion in the proximal mid segment, and ramus intermedius which has an osteoproximal disease. Right coronary artery is a dominant vessel. Circ is a small, non-dominant vessel. and right coronary artery is calcified with moderate lesion both in the proximal segment and the mid segment. Now, if you look at this 72-year-old male patient with the anterior wall STEMI in cardiogenic shock and with a lot of comorbidities, the question is, which is the culprit? And surely with the anterior wall MI, it is the LED with a total occlusion in the proximal and the mid segment of the LED, which is culprit. But proximal to the total occlusion in the LED, you find a severe calcification and also calcification of the left main. So what does this case become and what is the culprit? It is the left main LED calcified along with the total occlusion in the mid segment of the LED beyond the septal perforator, which is the culprit, and whether to look at the other non-culprit lesion because this is a TVD, and one has to look at the ramus, the circumflex, and the right coronary artery. So this was the angiography findings, which I just discussed with you on the distal left main, which is calcified, and the LED, which is a good size vessel with severe proximal calcification and an occlusion after the first septal perforator. Now the ramus intermedius, yes, is a big sized artery and it has 80 to 90% stenosis in the osteoproximal segment, which extends up to the mid segment of this good size ramus intermedius. The circumflex is a non-dominant small sized vessel which has a diffuse disease. The right coronary artery is a calcified artery with a 60% proximal plaque and a 50-60% lesion in the mid segment. So this is a coronary angiogram which was sent to me. And if you look at the lesions, the left main roof is calcified. And if you look at the LED, right at the very just beyond the ostium, you see a critical narrowing here in the LED. And you also see that there is a very diffuse disease in the beyond the proximal segment of the LED. Yes, the circumflex is diffusely diseased but non-calcified. And if you look at the ramus, it's a good-sized vessel supplying a good area of the myocardium. And you see the ostium of the ramus and the proximal segment of the ramus has got 80-90% narrowing, which though angiographically on the fluoro does not appear to be calcified. But if you just remove the dye and if you may look at the fluoroscope in this case, you find that there is a definite calcification, both in the left main, in the proximal LED, in the mid LED, and also in the proximal segment of the ramus. So here again, this is the aleocaudal view, which is the best view to see the severe calcification. And here you also see that just beyond the ostium of the LED, there is a stenosis with severe calcification, and you see a total occlusion here of the LED artery. Now, if you look at the ramus here, you see that just beyond the ostium of the ramus, I would call it an osteoproximal disease in the ramus, because if you try to balloon dilate and debulk this particular lesion in the ramus, you will end up extending the stent into the left main. And therefore, you will have to decide, because there is also some kind of a plaque in the distal left main, whether you will take this particular ramus as a side branch and then do a crush with the balloon in the LED and then stent the proximal LED and also the mid-distal LED. So this is the aleocaudal view, and this is the areocaudal view, which again shows a severe stenosis in the proximal segment of the ramus and also at the ostium of the LED with total occlusion of the LED after the septal perforator. Now, if you look at the right coronary artery, it looks like there is an ectasia, a small aneurysm, both in the proximal segment and in the mid segment, and there is a calcification along the body of the right coronary artery. And also you see that there is some lesion, about 60% lesion. Unfortunately, imaging has not been done in this case. I assume that in presence of a cardiogenic shock with this critical hemodynamically unstable patient, whether imaging would be possible, or even physiology with the FFR or IFR or RFR would be possible to see which is the most critical lesion. Now, what one would consider in this case is maybe not touch the right coronary and the ramus, but maybe during the index period, one may have to consider during the admission, the imaging and the physiology to both the ramus and the circumflex and the right coronary artery. Now, this 72-year-old male patient in cardiogenic shock with anterior wall MI and multiple comorbidities and a high Syntax score, almost more than 33, what do you do next? So the problems, as I told you, is the anterior wall MI, the cardiogenic shock, the heart failure, the TVD, the comorbidities, and whether to do culprit or to do all vessel PCI. Now, if you just consider STEMI with the anterior wall MI, PAMI would be the treatment of choice in this case. And if he's presented with heart failure and cardiogenic shock with high lactic acid, one would definitely consider an intra-aortic balloon pump. How much you'll be able to improve the cardiac index with the intra-aortic balloon pump would be little questionable and depends on the kind of augmentation in the diastolic pressure that you will get with the balloon pump. But surely an impeller with a mechanical circulatory support would be a good option in this patient. Now, as we know, this particular patient has a triple vessel disease. We know that the left main and the LAD is calcified. We know that the LAD is occluded. We know that the large ramus has an osteoproximal calcified severe disease. We know the right coronary is a dominant vessel with ectasia, with calcification, and with a moderate to severe disease in the proximal and the mid segment. We also know that he has multiple comorbidities. He's an aged person. His creatinine is high. He's got a CKD. He had a stroke about 2 years back. He's got a meningioma, which has been detected but not operated. He has very calcified arteries. He has a high Syntax score. He has hypertension. Now, would you just do a culprit vessel left main to LAD and open up the total LAD and just attend to the LAD? Or in the same time in a cardiogenic shock, would you also attend to the ramus and also to the right coronary artery? So this will remain questionable and would all depend on the hemodynamics of the patient during the angioplasty that would, when the culprit vessel angioplasty that you do, yes, you will have to open up the total occluded LAD. And obviously, you may have to extend your stent also into the proximal LAD, and if required, and if you are doing the ramus, you may land up doing either a DK crush or a mini crush, but DK crush may not be possible in this cardiogenic shock situation unless the hemodynamics are favoring you and unless you have an impeller device by which you can do a DK crush after opening the total occlusion in the LAD. Also, with the total occlusion in the LAD, to put the devices, especially debulking devices, through the very calcified LAD and the left main would definitely be a challenge in this case. Now, whether you would use a rotablator in this situation is another issue because the patient is already in a cardiogenic shock, and whether you would consider rotablator. Calcification with thrombus in a STEMI setting, a rotablator can be a challenge and produce a no flow, no reflow situation, and would produce no blush at all. And the myocardium distally may get totally stunned, and the microcirculation may get totally occluded in such a case. And that would be a big challenge of doing a rotablation in a STEMI situation with a cardiogenic shock in this calcified mid-LAD occlusion. So how would I treat the patient? Yes, I would definitely want to stabilize the hemodynamics of the patient by inserting an intra-aortic balloon pump. Now, I would do that in the ICCU before wheeling the patient into the cath lab, or I would do it in the cath lab itself. Now, after doing an angiogram on an IABP, I may consider putting in an impeller device to give the mechanical circulatory support. Yes, ECMO is another option, but it uses much bigger venous and arterial catheters. And if you can, and the patient can afford to have an impeller device as a mechanical circulatory device, that would be the best option in this patient. Tandem heart is another MCS device which we use, but we do not have it, the tandem heart presently in India. Yes, I would consider PCI to the calcified LED occlusion beyond the septal perforator. Now, would I use a rotablator? As I told you, that with calcification and thrombus and with a challenge of no reflow after using a rotablator would be a challenge for me. Now, if I'm doing a rotablator and if there is a slow flow, no reflow, and with the low blood pressure on a high BP, if it is not maintained, and if I have to use vasodilators like a sodium nitroprusside or even nitroglycerine or NTG or adenosine to be given intralesional, it may produce hypotension. Adenosine and sodium nitroprusside intralesionally with the microcatheter to be given distally into the LED would definitely be a challenge in this case. Now, using IVL could be a good option in this case because the lithoplasty balloon, though a bulky device, would need some kind of dilatation with an OPN or an NC balloon. OPN is a high pressure balloon. To create a channel for this bulky IVL balloon to get into the mid segment to the distal LED would be a challenge with IVL. But IVL would be a good choice in this case instead of a rota. But if you have the excimer laser, that would be very good because excimer laser would vaporize the calcified plaque and also take care of the thrombus. So when you have an acute situation where you have both a thrombus and calcification, excimer laser could be definitely a good option. But in your country, if you don't have an excimer laser, an IVL could be a next choice. But IVL being a bulky balloon, to advance it into the mid segment totally occluded LED, unless you prepare the bed quite well with the NC catheter balloon, it would be a challenge to also advance an IVL into the mid distal segment of the LED artery. Now, for this calcified artery in a STEMI with a thrombus, whether you have used excimer laser or IVL to create a good vascular bed, and only after you've created a good vascular bed, you would be able to do an imaging and then deploy an deploy a long drug-eluting stent and also post-dilate the stent. Now, the issue is that also there is a calcification in the proximal LED with a lesion beyond the ostium of the LED. And if you are covering up the left main to the LED, you'll be worried about the ramus because there's an osteoproximal disease in a very good size ramus. So you may land up considering the ramus as the branch and hence treat the ramus first with a mini crush into the left main LED stenting. So after you drug-eluting stent deployment into the into the ramus, after you prepared it well with a balloon and even an OPN, and then you can do an imaging and then put a stent left main to LED, cutting across the and then end it with a kissing balloon and a pot to the left main. Now, if you have to image also these vessels, it will be a challenge in a cardiogenic shock. Yes, imaging can be done with IVUS, and IVUS would be the best here to understand the extent of calcification, to look at any intimal calcification or a medial calcification or a superficial calcification or just adventitial calcification. Also calcified nodules and the extent, the length, the thickness, and the diameter by which the calcium is covering the coronary vessel would be detected on the IVUS. Now, I use the MLD max of an OCT, which is from Ziad Ali, also during the IVUS procedure, and I try to understand with the virtual histopathology on an IVUS to look at the morphology of the plaque. I look at the length of the lesion, the landing zone, and the diameter of the vessel so that I can also know the kind of diameter of the stent that I'm going to use. And now that we have the HD IVUS, which is 60 megahertz, my life has become easy. And I feel that when I don't want to use a contrast material, using a 60 megahertz IVUS has become a good option for me. Yes, after deployment of the stent with the same IVUS, I can also look whether there's any medial dissection. Though on an OCT, the medial dissection and the expansions look much better. But also if you train IVUS eye, you will be able to also look at any distal or a proximal dissection after deployment of the stent. Look at the proper apposition of the stent struts of the arterial wall and also the expansion of the stent. In this particular case with STEMI, OCT will definitely be an issue because of the dye that you have to inject during the OCT. And if you are going to do a left main to LED because of the calcium in the left main LED and the stenosis in the just beyond the ostium of the LED, I would not prefer a OCT in this case, and I would use a HD IVUS 60 megahertz, but use the same information which I get on the OCT by using IVUS, the MLD Max. Yes, I would use FFR in this case, particularly for the right coronary artery, which has a moderate lesion, which has ectasia. And for the LED, because there is a total occlusion, I would definitely do a PCI of the LED total occlusion. Now, proximal LED with the angiographic eye looks like a severe stenosis just beyond the ostium of the LED, but one can, after opening up the total occlusion, the LED, one can do a IFR, RFR, which are cousins of the FFR. And then, these will become easy in a cardiogenic shock to do. Because if you try to inject adenosine, you will develop more hypotension in a cardiogenic shock situation. Now, if the FFR is negative, the IFR or RFR is negative, after you've done a PCI and deployment of the stent to the mid segment of the LED, you may get away by not attending to the proximal LED to left main, and then plan the ramus at another time. During the same index period, but all would depend on the hemodynamics of the patient and how he improves after you've restored and done a PCI and revascularized the LED. So ramus, I would do a PCI, but as I told you, it would just depend on the hemodynamics after I've attended the stenting and PCI to the total occlusion in the LED. But I would definitely prefer to do it during the index admission, but only if the creatinine permits and the hemodynamics of the patient permit, and if I'm able to inject contrast material, and all will depend upon so much on both the blood pressure, the oxygen saturation, the augmented pressure, on the intra-aortic balloon pump, or the pulsatility if I'm using an Impella device. I would do a bedside echo also in the cath lab or in the ICCU where the patient is admitted to see for the wall thickness, because any other viability study will be impossible in this patient in cardiogenic shock. So looking at viability study like a cardiac MRI or a stress PET or a myocardial perfusion scan will not be possible. And therefore, I will have to go with my clinical judgment on looking at the wall thickness in the septum, the anterior wall, the lateral wall, and the apex of the heart, which will surely be hypokinetic to akinetic. But whether if it is thinned out and totally aneurysmal, then there is maybe no point in trying to even do an angioplasty with stenting to the total occlusion of the LED. Yes, in this case, I would definitely prepare the kidneys because its creatinine is high. With proper hydration, I would tell the anesthetist and the intensivist to hydrate the patient well, but at the same time not hydrate to the extent that he develops pulmonary edema. I would definitely limit the volume of contrast, and that is the reason why I was thinking of doing it on an Impella device, so that I would just put 2-3 wires and use the wires as my landmark to position my balloon and stents in this particular case, and even the debulking devices would have a marker. So the LED marker could be on the basis of the wire, it could be on the basis of some spine or some vertebrae, which or even the gastric, the diaphragm, to see where I'm going to position my IVL balloon or my laser catheter without injecting much of contrast material. A non-osmolar contract like a VC pack would be helpful in this case. But again, this is a little controversial on the use of VC pack. But all my patients with low EF and cardiogenic shock, when we take them with PAMI, we try to use a limited volume of contrast, and I prefer to use a VC pack. And I try to use wire markers to position my balloon and stent. My goal in this case would be to achieve TIMI3 flow in the LED, but besides the TIMI3 flow, which is epicardial flow, I would also try to achieve the blush in the LED territory. And this blush in the LED in the myocardium may do the trick in stabilizing the hemodynamics of the patient and restoring the blood flow to this calcified LED artery. And this may work out to give me a good acute outcome, both in terms of hemodynamics, in terms of lumen in the LED artery, and in terms of restoring the blood flow, both macro and microvascular, with a good blush. Post-procedure, I would keep a very close watch on this patient for his blood pressure, for the intra-aortic balloon pump, and see that there's a proper diastolic augmentation. I would keep a very close watch on his urine output, on the creatinine, on blood counts. I would keep a close watch on his groin, especially when I've used an impeller device. Though I will remove the intra-aortic balloon pump, and through the same access, I would use a 14 French sheet for an impeller device. But I would look at the limb very well for the peripheral pulses, Doppler for limb ischemia, electrolytes, serum lactic acid will have to be monitored. So very close monitoring post-procedure would be the responsibility of the interventional cardiologist. It's not just I have restored the LED with opening the total occlusion in the LED. And even if I've done a mini crush to left main ramus, taking ramus as a side branch and left main LED as a main branch, that my duty will get over. I may have to sleep in the side room of the ICCU to see that this patient is extremely well monitored hourly, because the next 24 to 48 hours to 72 hours are extremely crucial for this very comorbid patient. So all cardiogenic shock, what is important to know is it's basically not only the arterial pressure and systolic hypotension of 80 to 90 millimeters of mercury, but it's a reduced cardiac index of less than 1.8 liters per minute, or less than 2 or 2.25 liters per minute on inotropic support like a noradrenaline or a dopamine. These patients have elevated lactic acid, elevated filling pressures, and they have high right-sided pressures. So you may need a Schwann-Ganz to also monitor the RV pressure, the pulmonary capillary wedge pressure, because the main problem is the inadequate tissue perfusion, which is the end organ tissue damage, both at the peripheral and the kidney level. And here, due to cardiac dysfunction, because the patient already has a CKD, it would be a challenge in this case. I will just show you one or two of our recent cases. This was a 65-year-old patient who had presented to us with dyspnea on exertion class 3 and angina, and he was admitted on just pre-COVID on the 16th of February. Our COVID lockdown started on the 21st of March 2019. And at another center, he had already undergone a CABG 1 year back. And when we did, he came to us with the low blood pressures, and his EF was only 25%. Now we put an intra-aortic balloon pump and did an angiography on him, and he had a severe TVD, and all the bypass grafts were blocked. Now, in this case, the circumflex was a very dominant vessel and right coronary was non-dominant. So IBP was inserted on the 19th of February in the intensive care unit. And then I took him on the cath lab with a systolic blood pressure of 110 and a diastolic blood pressure of 76. This was 2 days after we stabilized him on IBP and adrenaline, and we saw that all the grafts were occluded and blocked, and he had a severe triple vessel disease, left main LAD, with a severe stenosis in the calcified dominant circumflex artery. In the cath table, we removed the intra-aortic balloon pump, and through the same access site, we inserted an Impella device. And I did this case on an Impella, where I took the left main to the LAD as a side branch and did a mini crush with the left main to dominant circumflex, stenting with the support of an Impella device. This patient had a heavily calcified lesion, so I had kept the IVL catheter, lithoplasty balloon, and also the laser catheter on a standby. And we had the engineers of the laser, because we've just introduced the laser about 21 days back in my hospital. And but fortunately, to my good luck on the Impella, I could open up the stenosis initially with the NC balloon and later with the OPN balloon. I went to 35, I came down, and at 40-45 atmospheres, I could open up the lesions in the distal left main. And fortunately, to my good luck on Impella, at every balloon inflation, the patient was very stable despite having so I could manage this with the mini crush technique. This was another patient who had a TVD, and he was admitted on the 16th of November with heart failure. And he's a diabetic since 2003 and high NT-proBNP. His A1C was 10.3 and troponins were elevated. So heart failure with ACS, and this was the ECG which he presented. Now the question here was, because this was a multivessel disease, whether I would just take care of the LAD or whether I would do also the circumflex and the right coronary artery, as the case which was given to me by Dr. Mohsin. So the conclusion in these cases are whether multivessel PCI during a STEMI can actually may have to be done. But all this will depend on the hemodynamic status of the patient. And despite the clinical trial and the culprit shock and the results of culprit shock, that we do the culprit vessel first, many times in cardiogenic shock, we may also have to attend to the non-culprit vessels to stabilize the patient's hemodynamics. So all this will also depend on what kind of cerebral protection in cardiogenic shock you will give to the patient, what kind of mechanical CPR has been done on the patient, and whether you will use an ECMO and Impella, which will all depend on the outcome of the case that you will do. We have done a couple of cases on ECMO, about 8 cases with multivessel disease and STEMI. Unfortunately, almost we had a mortality of 40 to 50% in these cases. And despite us struggling so hard for a couple of nights, my residents have been keeping awake, keeping a close watch on these patients with multivessel disease who present with cardiogenic shock. After doing the culprit, we have also attended the non-culprit, and we have either done an Impella or ECMO. Yes, on IBP also, but we had a higher mortality with the multivessel PCI during STEMI. Yes, as we all know, that radial approach for STEMI is recommended to reduce the bleeding complication. But in cardiogenic shock, many a times, and in most times, I will tell you, we had to use also the femoral access. And we landed up using a bilateral femoral and one radial in these cases of cardiogenic shock with multivessel disease. Many times we had groin problems, especially when we used bulky devices through the left femoral for mechanical circulatory support, and we did have limb ischemia, and 2 of our patients also landed up with embolectomy in the middle of the night, and we had to remove the impeller device. In one patient, actually, we had a problem also with the IABP, where the patient, while removing the IABP, developed a big thrombus at the left femoral artery and developed severe limb ischemia and required embolectomy in the surgical theater. We tried a Fogarty catheter in the ICSU but did not work, and the surgeon had to open up the groin and do a proper embolectomy to restore the left limb circulation. Yes, ultrasound guidance for access we have started doing now, and we found that this is a high success rate and less complication. But up till last year, we just used to do fluoro guidance to puncture the femoral artery. So we all know the access complications, particularly with these mechanical circulatory devices that we are using now, and a proper access puncture and getting proper access becomes extremely important, because eventually in a STEMI and cardiogenic shock with triple vessel disease, you may have done a good job, but you may land up with other complications. And particularly in this particular case, your case, where patient also has a lot of other comorbidities like CKD and meningioma and a stroke and hypertension, and he's presented with a triple vessel disease and cardiogenic shock, and an elderly person. So this was a recent case that we did, which had a severe calcified distal left main. And you see there's also a proximal LED disease. Your particular case, Dr. Mohsin, which you've sent me, has also got a disease in the just beyond the ostium of the LED, but your left main is clear. Now here, this patient also presented to us with STEMI, and we were very reluctant to use a rotablator for reasons which I already told you. And fortunately, with IVL, with 20 passes, we could actually do this particular case. Dilatation was done with NC balloon. We created a passage, and then we use an IVL balloon. And the waste was removed and resolved after 20 passes. And we could achieve a widely patent TIMI3 flow with a good blush after deploying a 3.5 millimeter stent, which you can see here, and also been able to dilate it with a 4.5 NC balloon. This was another case which we handled a few weeks back. You see there is the left main plaque here. The ostium of the LED also has a plaque, but the main problem here was a very heavily calcified circumflex at a tortuous bend. Now, here we tried to use an OCT because the creatinine of the patient was normal, but we couldn't advance the OCT catheter. So I could have used IVUS, but we didn't use IVUS. Instead, what I did was I dilated with the NC balloon, and then with the guide liner, in this case, I think we use a Guidezilla, and then we used an IVL catheter followed by successful IVL therapy. With 6 cycles, the case was completed, and then we deployed 2 long stents and got a good result. We have not touched the left main and the LED ostium in this case, but we kept it right at the ostium of the circumflex and deployed 2 stents after we dilated with IVL. No imaging was done in this case. Even after the deployment of the stent, then we did a OCT because I'd already removed the OCT catheter. So then I did a OCT to look at the morphology, the max position of the stent, and then post-dilated with a 4.5 NC balloon, and then repeated the OCT. And we got a wonderful result. I don't have the OCT images now. Otherwise, I would have shown you. But pre-PCI, there was no OCT done. It was only after using IVL and the DES, and then post-dilating with a 3.5, we used a OCT, and then opposed the stent on the arterial wall with proper expansion with a 4.5 NC balloon. So thank you very much for a very, very patient hearing. What I have seen in this particular case, I would like to know what the operators did, but I'm sure that this particular operator must have done maybe differently, maybe the same way, and I would be very much interested to know the same. Thank you very much for your very, very patient hearing. And I thank the chairperson, Dr. Chowdhury and Dr. Mohsin Ahmed of giving me this opportunity on my thoughts on this particular case. Thank you and salam alaikum.
Thank you, sir. I think for the fellows or also our panelists also so much delighted presentation because you touch everything. As Dr. Kaisar Nasrullah Khan also nicely presented the cases. 9 points you touch from the beginning is the cardiac shock, also kidney lesions, also low contrast, also then the kidney functions and the groin preconditions and the management of the vascular access. I think for the fellows, you can gone through this thing from our YouTube channels and you can repeatedly gone through this thing. You can expert like Dr. Marchand, Dr. Kaisar, Dr. Sams. Dr. Professor Dr. Saidur Rahman Khan.
Yes.
Yeah.
What can I say? Dr. Shams Munwar has chosen a case. It's like throwing a stone in the beehive. So many, so many bites now there, and lots of discussions are there.
Yeah, yeah.
That's the most important thing here. I usually think in a different way for this case, especially for the fellows, is that this sort of cases are like 3H. First thing is that it's a case of absolute HBR, that means high bleeding risk case. Just meeting all the one major and two minor criteria of the ARC. And so HBR case means you have to be very, very much meticulous about the bleeding risk also later on, even peri-procedural and post-procedural. And second is HTR, possibly because these patients are actually with high thrombotic risk along with high bleeding risk. And the third one is, this is a case with a STMI, is with HTB. That means huge thrombus burden is there. So this 3H is there for this case. So how I will deal with these things, actually, this sort of, we are not still in the era of ECMO, IVL, or OPN. So we have to forget these three things for now. Just for now. So in the middle of the night or at any time, when we'll face this sort of cases, I usually like to go through or look at the echocardiogram very much meticulously, bedside echocardiogram, before taking the patient in the cath lab to see whether the LAD territory is at least viable, or at least it is not aneurysmal or anything. If it is aneurysmal, then actually we don't have any hope. So primary PCI, whether or not, or sending it for surgery or something, it's not at all in my brain at all, because this is hemodynamically severely compromised patient with cardiogenic shock. So it's a class 1 recommendation to open the artery and to help the patient. So we'll go for the primary PCI, no doubt about it. Considering the access site, obviously, I will go for the transradial approach, though it is sometimes very difficult to find out the pulse, but if for an experienced operator, it is possible. And the third thing is that for these sort of cases, the support, that means assist devices we don't have, but IABP, even the Dr. Marchand also is telling that 40% there is no benefit, 50% has got the mortality. Trials are also telling. Manual thrombus, that IABP doesn't have that much value in that case, especially for some cases by the physician's discretion, you can take the IABP, but it's not a mandatory or class 1 recommendation at all. For manual thrombus aspiration, if you go for the case itself or procedure itself, only the TAPAS trial has got some benefit with the manual thrombus aspiration has shown, but total test, infuse MI trial, they are not telling anything. So the guideline is also not telling that manual, rather it has degraded the importance of the thrombus aspiration. So and for this case especially, I'm not going to go for that one, because from left main up to mid LAD is hugely calcified. I don't like to take any bulky device until unless I'm opening the LED. So what I will do, I will take the regular workers wear, and I will just try to find that whether obviously if it is calcific, but if you can remember the Renu Virmani and Roxana Memeran's physio or pathophysiological characteristics of calcification, it's obviously the left main is hugely calcified, but always it has been told that in the left main, possibly it is a deep calcium. So deep calcium is making an unstable plaque. So it's not a big problem. It's like a ceramic. So through this pathway, everything can be crossed. But the problem is there where it is totally occluded. That point, whether there is an nodular calcification is there, whether it will be very much hard to open. So that's why. So I'll take a regular horse square to see the might of the calcification. I think obviously it will open. We can cross. We can take the wire through the occluded segment, and then I will test it by directly by an NC balloon, rather considering the size of the LED, at least 2.5 NC balloon, to see how much it can dilate that occluded segment. And obviously, I'm not going to go for any sort of thought or any sort of worry for the ramus intermedius, because at least it has got a TV3 flow now. And if the echo shows that it's not an aneurysmal LED territory, so I will try to open and vascularize the LED itself. And possibly after an NC balloon, I will go for, if it is inflating well, then I will go for a go for an stenting of that occluded segment, and possibly and I'll go to the proximal LED for maybe for another stent, or it's better to take the 2 stents. Sometimes it's okay, but never ever for the ramus itself, or I'm not going to go for any bifurcation stenting there. Even the culprit shock trial or the complete trial, whatever you can tell, I can do it. Not any trial is telling that at the same setting, but they're telling at the same hospitalization time. So it's not a matter that whether I will have to take do the multivessel PCI at the same setting. If we do it at the same index hospitalization, that's also like a complete revascularization. So that's all I can say. And for CKD, obviously these sort of patients may have after procedural success, if it is a success, then usually what I see that cardiorenal syndrome actually not happens there, and actually the kidney becomes a little bit better. And for imaging, though I'm doing now lots of imaging, but for primary PCI cages, I usually don't like to go for imaging, because that one also can just invite thrombus to go somewhere else also. Thank you.
Thank you, Sadir Bhai. Thank you. I must thank Dr. Munwar, sir. This is a case of lots of learning points here. I think lots of questions here. Dr. Professor Akim Reza, sir. Do you hear me, sir? Professor Akim Reza, sir.
Yes, hear everything and learn many things.
Yes.
Just at this point, I don't want to discuss anything. I want to see the actual result, if possible.
We are desperately waiting to see the result. Comes by, just please show us that what is happening.
Before Dr. Munwar, because it's exciting, one of our colleague from Khulna, Dr. Abdul Manjur, did any question, Dr. Abdul Manjur? In the periphery, shock, yeah.
Thank you, sir, and Assalamu alaikum. Sorry,
yes.
If I got this case in my center, suppose in Khulna, so what actually this kind of case I already did. It is actually off-level procedure I did. I just did the POBA with a small balloon and keep the patient on a GP2B inhibitor and convince the surgeon after 2 or 3 days for the bypass surgery, sir. So that was actually, if this kind of case I have to wait, because I don't have any IVAs, I don't have other so much logistic facility. Actually, I don't have. So I think POBA maybe is a off-level option. I think so, sir. Thank you, sir.
Yeah, but this is a case of high bleeding risk patients, you know. So so GPI to be given of downstream GPI is also a very risky thing because it may invite hemorrhagic stroke or something like this.
Regarding coma in primary PCI, I like to differ.
Dr. Abdul Jamil, Dr. Abdul Jamil, please comment.
Doing plain balloon angioplasty in primary PCI it does not give good result. It opens close immediately after opening of the, and it does not stay open. So it is better to stent.
Yeah, Dr. Tanvir Ahmed, do you hear me? Dr. Tanvir? Dr. Tanvir, do you hear me?
Yes, sir. Yes, sir.
Yes.
Sir, actually, very interesting case. My only worry was, sir, this patient did.
Okay, Dr. Khaled John bhai. Dr. Khaled John bhai, do you hear me?
I can hear you. And very brilliant discussion, and the discussions are more or less everybody is in similar line, in similar approach to deal with the lesion. No doubt it's a very complicated one, because the Professor Saidi Roman said it is the same time both thrombotic and the bleeding risk is there. We are taking care the renal problems, but what we are doing for the neurosurgical care? Would we not involve a neurosurgeon for taking care of the meningioma? Because in the event of cardiogenic shock, there may be necrosis of the meningioma, and in the event of heparinization and the antiplatelet therapy, there is chance of hemorrhage into the meningioma as well. So we have to taking care of that also. We should involve in our team and neurosurgeon as well to take care of the meningioma. So thanks everybody for their nice discussion, and we have learned a lot and very complicated case. So the Professor Munwar sir has presented to us, and many things to learn from this. So let us see what he has done for the case.
Dr. Khondukar Asudjaman, Dr. Khondukar Asudjaman.
Thank you very much. Actually, if you look at the participant of today's webinar, you can see that there is no attendees. Only the faculties is here. It indicates the case is very tough, no doubt. And the second thing, if it happened in my cath lab, I will just call back the helicopter to catch up that Dr. Shams Monor and Kaisar Nasrullah and likes others, and then come back to my lab and I will just sit down. This is my comment. Actually, what happened, if I face this problem, definitely I will just revascularize the LED first. And in this case, definitely it should be the left main to LED. Definitely, there's no doubt at it. And later on, if there is no significant, that is, if there is TB flow is 3 or 2, I will not go for recanalizations of the ramus at the same time. And all the panelists, all the discussions already told like this. This is my opinion. Thank you very much. And I'm eagerly waiting for the actual scenario of this patient. What Dr. Shams Monor did.
Thank you. Now open your Pandora box, Dr. Shams Monor sir. We are waiting for opening your
Thank you
Pandora
very
box.
much. Thank you very much. Okay, as everybody has discussed, thank you very much to Dr. Kaisar, thank you very much to Dr. Marchand, and everybody else for actually I also learned quite a few new things which I didn't know. Anyway, this is actually not a nice case as you discussed it to get at the middle of night, particularly when your support service is not that great. and you don't have any senior colleagues next to you to help you out or advise you. So it was a difficulties in that way. Anyway, patient is in critical shape, so I had to do something for this patient. I decided to, as everybody said, to salvage the LED. That was the main target. The main thing about keeping the things in condition, try to keep the time minimum, gave a loading of clopidogrel and aspirin, and that's also not very high dosage, 150 clopidogrel and 150 aspirin. Just gave a little bit more extra heparin, that's all. Avoided the GP2B3 inhibitor. So the approach I had right from the beginning, because I thought patient may require IIBP. I'll require IIBP, I'll give a support. So I avoided radial, and radial was not actually not palpable at all. Guide catheter I took actually 6 French, extra backup. Guide wire I took my workhorse Sion Blue, tried this first, and balloon as you see with 2, 2.5, 2.5 like this way. So both, I actually wired both LED and ramus to safeguard the ramus, not to risk it. I intentionally avoided thrombosuction. I didn't think it was a good idea in this patient to give a bulky device and cause distal embolization. So I give a balloon, and you can see there's a calcified plaque which is not giving away very easily. But after giving that, the artery opened up quite nicely. To my surprise, the thrombus is not much seen anymore. Little bit thrombus, but not much. An artery opened up quite well with the one inflation. So I gave repeat inflation, little bit distally, and you can see the calcium not giving away here. But anyway, the calcium actually gave up a little bit later, which is not here. I took a stent, Lance Expedition 2.548, and to position it to long stent, covered the entire length and beyond the lesion, and keeping the strut, the marker right at the ostium, and deployed it. Stent opened up quite nicely. And if you see distally, it's giving good flow. Although blush was not great. However, LED opened up quite quickly. To my surprise, it didn't give me any much trouble actually. But patient's condition did not improve at all. Patient's blood pressure remained unrecordable. Patient remained very much symptomatic. In a way, patient was sweating like anything and nearly became unconscious. So I told anesthetist to get prepared. Sorry, show the post dilatation. So I told the anesthetist to get prepared with the ventilation and start to prepare the IBP. At the same time, I thought I've got a wire in the ramus. Let me try, because the LED result is quite good. Ramus may not give me that surprise because I have to save the patient. So I dilated, and it gave a quite quick, easily actually. Opened up nicely, and LED is not compromised. So I took a stent to ramus 2.523 Lance Expedition. I actually, while doing the stenting, kept the position here. What I did to avoid the left main, I kept a balloon inflated in the LED ostium, in the ST proximal, to guard the LED ostium, to make sure that LED doesn't get compromised, and deployed the ramus stent. And that gave quite good result actually. I thought the left main would be compromised. I have to do the left main stenting with the mini crush technique, but it looked quite okay. And to my surprise, within 30 seconds, patient's blood pressure came back. Patient blood pressure came back. I observed for another 5 minutes. Systolic blood pressure became recordable to nearly 80 to 90. Then I thought it's okay. I can leave the left main alone for the time being. This should be enough for him. So if the systolic pressure within 10 minutes went up to 90, 95, nearly reaching 100, so gave up the idea of IBP also. So that actually ended up by procedure. So I actually intention was for primary PCI to LAD only, but as patient condition was not really great and was deteriorating very rapidly, I had to go for the REMUS, to try for the REMUS at least. Although this is not recommended, as everybody has said, it's not widely recommended procedure in the setting of acute ST elevation MI. But I had to do it to salvage the patient. Good thing that this patient remained asymptomatic. It's over 6 months now, 8 months nearly, after PCI and with stable creatinine around 1.8. So the discussion actually, well, actually discussion has been done already. So nothing much to say. 3 strategies as said: culprit vessel only, multi-vessel the same sitting, and stage PCI in the index admission or afterwards. The data has been discussed already by Dr. Kaisar in detail, so possibly there's not much point going to that in detail. And as study has shown from the very beginning, 1991 onwards, this is guideline initially suggested, but later the premise study showed the patient with multivessel coronary disease undergoing multivessel PCI is not that bad. The patient number was not that great in premise study. Complete trial did also suggested the repeat revascularization in the index admission or right after admission, but complete trial did not include the cardiogenic shock patients. So that doesn't come into my patient here. The main important trial that worth discussing, as everybody has done, this culprit shock studies. Culprit shock studies are 2 studies in 2017 and 2018 reported in NEJM. And the investigators actually did a meta-analysis from 2 studies and published the meta-analysis in JAMA in August 2020 and reported in NEJM Journal Watch in September 2020. These 2 trials that registry showed more than 64,000 patients from 1,649 centers in the USA, and all patients with acute MI with cardiogenic shock. And this showed an acute MI population with cardiogenic shock. It includes both STMI and NSTMI. Multivessel PCI was associated with lower age-adjusted mortality, but with higher risk of in-hospital complication, as everybody's mentioned. Odd ratio 1:18 is quite high. In particular, the subset of patients with STMI, in-hospital mortality with multivessel PCI was higher, odd ratio 1:11. And overall one-year mortality did not differ between groups, whatever is the strategy. So if I take the culprit shock trial, then I have not followed the guideline. Although it's not the guideline clearly at the moment, I have to apply my own common sense in this patient. Keeping in mind this study, this is a big headache for us, keeping in mind that 70 to 80% patients with ischemic cardiogenic shock have multivessel disease. So dealing with them is a really nightmare for anyone. Discussion was really fruitful. I learned quite a few things from all of them. All of Dr. Kaisar and Dr. Martin, thank you very much for giving the information. My case actually ends here. Thank you.
Thank you, sir. I think excellent result, and patient is survived. 6 months, patient is good, asymptomatic, and kidney is very good. Professor Dr. Mirjaman, sir. Professor Dr. Mirjaman, sir. Professor Mirjaman, sir, please.
I think Professor Mirjaman has gone, left.
No,
Yes.
Yeah, sir.
Are you hearing?
Yes, sir.
Yes.
Okay. I told that by few minutes I shall have to finish my speech, as because it is 11 to 15 minutes to 11. We have learned from all the 3 speakers in different way, and finally the main person who has rang the bell, he has shown his charisma, meaning that he has done in his own way and the result is excellent. But we have learned how much we have to go rota, we will have to go IVL, but he did not require anything. So we are very happy seeing the result, as because we have not that facility in our hand. Thank you all. Thank you, Professor Chowdhury, Meskat Ahmed, and all of IPDI and the participants. Thank you. Assalamu alaikum.
Thank you. Thank you. Now, Professor Kimrida, sir. Now, Professor Kimrida, sir.
Thank you.
Sir.
Actually, it's a learning. That is, every time we don't have to follow every guideline. We have to follow our own judgment and individual patient. That is the true during the Cathlab procedure. If we have to follow all the guidelines for all the patient, then we cannot perform all the patient very well. This is my learning from this session. But every points we have to be very much aware, and we have to be in mind that we have to follow the guideline first. If not, then the thing is probably depends upon the operator. Actually, it is a learning that every operator did their case in their own way, and subsequently these things are coming together and give a result and give a guideline. So I must thank Dr. Shams to do the case. Very simply, he started, but he has to do the complicated case when the patient become stable. So this is the learning of this session, that every operator have to do and have to judge for every patient individually. Thank you very much.
Thank you. Dr. Waliul Islam, Professor Waliul Islam.
Wali, unmute coin, please.
Thank you very much, Dr. Shams Munwar, Dr. Kaisar Nasrullah, and Dr. Shahid Marchand. Really, the case is definitely a complicated case, and the way Dr. Shahid Marchand has elaborated his management of this type of case, really, he started from A to Z. And we learned a lot from his every single steps of descriptions, starting from IBP, ECMO, then also IVL, then Excimer laser. So many things he touched. And this is really like a good teacher's lifetime achievement experiences. He elaborated in such a way that definitely it will be a good guideline for us in our future cases if we are having these sorts of cases in our Cathlab. So I think we learned a lot, and Dr. Kaisar Nasrullah also explained very nicely, and Dr. Reza and Dr. Shams Munwar presented very nicely. Thank you very much indeed.
Dr. Arifur Rahman Shojol. Dr. Arifur Rahman Shojol. Last comment from you.
Thank you, sir. It's a great opportunity for us to hear from the masters. We have nicely visualized a case which is very complicated for mid-level operators, and the way they have performed and they explain the every steps, I think it will be very much helpful for operator like us, those who are in the learning stage. Thank you, sir, and we expect this. How should I treat this session? We'll get more exciting sessions in coming days. Thank you, sir.
Thank you. Now, Dr. Kaisar Nasrullah Khan, you explained the case very nicely. Dr. Kaisar Nasrullah Khan.
Yeah, thank you so much. I would like to congratulate Dr. Shams Munwar Bhai for his brilliant presentations and the way he managed the case. My take from this case, all discussion is three. One is that before doing this case, one, you should have as much as possible hemodynamically stable position, either by giving inotrop or giving, if possible in my country, IPP, and if in future Impella. If you have got a very good hemodynamically stable platform, then doing this case will be easier for you, whatever required. It is a single stent with provisional stenting, or upfront double stent, or if you need to do rota or IVL, whatever. So first basic thing is you need a very good hemodynamically stable platform. The pressure pulse, this should be stable. For this you need inotropes, good intensivist, good IAP or impeller, whatever. Second take is that for me, doing this case, whatever is required very early and fast, act fast, act now, and keep it very simple, very simple. Third take is for me, what Shams Bhai did, guidelines are guidelines, but you have to act as a human being. If only guidelines are to be followed, then any Google or any computer can treat a patient. You don't need any doctors. So even culprit shock trial has said that mortality is higher if you do multivessel PCI. But what Shams Bhai has done, hats off to him, he did the culprit vessel, LAD, and after doing that LAD, the long LAD, he did a long stents, and you have seen the outcome. It's very good. But even then, the pressure did not rise. So he can't leave the patient saying that I've done culprit shock trial and I did the single vessel disease. I will do the ramus later on. Patient will die. So at that time, he has to work as a doctor, humanly doctor, which he did. He took the ramus, and after doing the ramus, what he said, the pressure went up within, I think, half a minute or 1 minute. So it could be that LAD territory is already dead. Maybe the patient has come late, a bit late, or whatever reason. But ramus was viable territory, and it's a big branch. When he did the ramus, the patient pressure has gone up, and patient is surviving till now, came to him as a follow-up. So guidelines are guidelines, but you have to use your brain, your experience, your everything to treat the patient. That's my take from my Shams Bhai. Thank you so much, Shams Bhai.
Thank you.
Mohsin, can I add something?
Yeah, last comment from Dr. Abdul Jamil Bhai. Last comment from you. Yeah.
Everything was discussed nicely, and just to add one thing, what Shams Bhai did, he didn't went for any thrombosuction. Now thrombosuction is not recommended that much, as the outcome is not good or not improved with thrombosuction unless a very bulk of thrombus is there. No thrombosuction should be done, and thrombosuction, imaging, rota, all these things kills a lot of time. It's better to keep any procedure, including primary PCI, keep as simple as possible. And outcome does not differ much with the complex procedure and the simple procedure, even in bifurcation and primary PCI. What I follow, what Shams Bhai did, I try to maintain like that from the beginning of my career, and that gives reward, no doubt about it. Thank you.
Thank you. Thank you, everybody, especially our Dr. Shams Munwar sir, to choose a nice cases for a lot of thinking process here. And Dr. Kaisar Nasrullah Khan Merchant, I think they touch every points of the learning points. So our fellows can gone through our IPDI YouTube channel regularly, so they can build like Dr. Shams Munwar, Kaisar Nasrullah Khan and Merchant. Now I request Professor Dr. Chowdhury Meskat sir, please closing our session.
Thank you. Thank you.
Mr. Bhai, just 1 minute. Khaled Professor হইছো, খাওয়া দাও. Thank you.
খাওয়ার কোনো সমস্যা নাই, খাওয়া হবে ইনশাআল্লাহ।
Okay.
ভ্যাকসিনটা দিয়ে নেন, তারপরে খাওয়া হবে।
Meskat sir. Yeah.
Thanks to all the speaker. We really had a fascinating evening of interventional cardiology. Actually, we live, move, and have our being in an age of evidence-based medicine. But there is another medicine we know as eminence-based medicine. Beforehand, I said our today's speaker do have the authority, do have the authenticity, and do have the integrity in their interventional life. So they are the eminent people, eminent interventionists to make some decision which goes beyond the guideline. Today, we had conflict on 4 or 5 issues where guideline does not go. For example, the route of access, vascular access. Generally, radial route is being chosen, but reasonably here the femoral route has been taken. The dictum of doing only the infarct-related artery in case of shock, we have seen how the operator has not been strict to that point. There was concern about using the IABP, and we have heard from the speaker that some of the speakers do prefer IABP, and it really works in some cases. As we said, we should not always rely on the evidence. The decision of the eminent people are there, and we are very fortunate tonight. We had 3 eminent speakers. We had eminent panelists, so that they have made their comment in their own way, and we have learned so much. Thank you, everybody.
Thank you so much, Beximco Pharma. I last thank Beximco Pharma. They're doing a tremendous job last 1 year during COVID and pandemic. Thank you, sir. Goodbye. Allah Hafiz. Kaisar bhai, Allah Hafiz. আমরা মেজবান খাবো, মেজবান খাবো, খালিক ভাই মেজবান।
খালেক বেটা খাওয়া।
আরে চিটাগাং অ্যারেঞ্জমেন্ট হবে ইনশাআল্লাহ। কিছু পে করো।
আপাতত আইপিডিআই অফিসে হয়ে যাক স্যার, শর্টকাট।
কোনো শর্টকাট, হ্যাঁ।
আইপিডিআই অফিসে শর্টকাট হয়ে যাক স্যার একটা।
হ্যাঁ, মেজবান। ওকে।
আচ্ছা, ঠিক আছে। কাইসার জানাচ্ছি যে আমাদের রেজাল স্যারের ওয়াইফ ম্যাডামও কিন্তু প্রফেসর হয়েছে আমাদের সাথে।
ও আচ্ছা। তোমার খাওয়ার আগে এই খাওয়া খেতে হবে ভাই। অনার ইউর সিনিয়র্স। তুমি তো ব্যান হতে পারো না, তাই না? আগে রেজা ভাই আগে খাবে, তারপরে খাবে, আর দিবে। দুটো অকেশন হবে।
আচ্ছা, কাইসার এই যে ভ্যাকসিনকে বলেন যে তাড়াতাড়ি ভ্যাকসিন গুলো দিয়ে দিতে, তারপরে আমরা খাওয়া দাওয়া শুরু করব ইনশাআল্লাহ। আর শামসকে তাড়াতাড়ি
লাগবে না।
ঠিক, এক্স্যাক্টলি।
শামসার আল্লাহ হাফেজ স্যার। ওই যে তামজিদ ভাই,
শামসকে ছাড়েন, খাবার ঠান্ডা হয়ে যাচ্ছে।
তামজিদ ভাই।
ওকে, বাই, গুড নাইট।
আসসালামু আলাইকুম।
আল্লাহ হাফেজ।
আল্লাহ হাফেজ।
মঞ্জুর ভাই, খুদা হাফেজ।